Hey guys, it's Dr. Krad. Here is a cataract surgery that I initially did not want to perform. On slit lamp exam, you can see calcific folds in the anterior lens capsule, so I knew it would not be a routine case. But more importantly, she has a long-standing history of total retinal detachment on ultrasound with no light perception vision. Without vision potential, I wouldn't want to put her at unnecessary risk. If she had vision potential, I would have been more motivated to sign her up for surgery. However, there is more to this cataract than meets the eye. I wasn't considering all the consequences of having such a cataract. This is a relatively young patient, only in her 40s. Socially, the cataract has been a nightmare. With a white pupil, it would trigger people to look at her awkwardly, asking why her pupil looks white. This never even occurred to me. Despite that, I really emphasized that surgery would not bring her vision back due to the long-standing total retinal detachment and no light perception vision. She definitely understood that. She didn't have false hopes of visual recovery, but despite that, she was really motivated to have it removed. I told her that if she sees a retina specialist and they think it's okay, I'll help her remove the cataract. So she goes to the retina specialist and they clear her, saying that since she's so young, there may be benefit in the long term in removing the cataract. It could prevent eye pain from inflammation and glaucoma problems, and of course, it would also help them see the posterior segment better. So here we go. I stained the anterior capsule with trypan blue. The anterior capsule is bundled in the center like a volcano. This is from fibrotic contraction and possibly weak zonules. Oftentimes, these contracted and calcific anterior capsules need to be cut with scissors. I always wondered if Zepto would be able to cut through a fibrotic capsule. So here I am trying it. The anterior chamber is a bit deep and I need to make sure that I get good apposition with the anterior lens capsule. This is the new version of the Zepto where you use the phaco pedal to control both suction and to trigger the capsulotomy. After I get good apposition, the capsulotomy is performed. Look how immediately after the capsulotomy is performed, the capsulorhexis widens to a much larger diameter. This is because the central pulling forces by the central capsule contraction has been eliminated. So now the zonules have nothing opposing their tension, which pulls peripherally. It's kind of like the opposing centripetal and centrifugal forces, but without the motion of an object. In any case, the capsule widens dramatically. There are two tags that I see, one subincisional and the other at around my 4 o'clock. I'm going to pull centrally to separate the tags. A backup option is to cut them with scissors, and there may be a radial tear subincisionally, which I will watch carefully, but I can't tell because it might be due to poor staining. If the area peripheral to it is calcified at all, hopefully it'll resist running out more than it has. I don't get a good hydrodissection or rotation, so I viscodissect. After cracking the nucleus, I use a two-handed method of rotating the lens so I get maximum spin with minimal tilt. Considering the capsule calcification, I'm pretty impressed with the Zepto. I'm expecting to see very weak zonules, but during the surgery, I'm not seeing the capsular bag or the capsulorhexis edge shift around, but I am doing my best not to put stress on the zonules. And fortunately, I am able to remove the cataract's nuclear material without any problems. I attempt to keep the AC formed at all times. The cortex present is very plaque-like. In addition to less than ideal zonule strength, this may have contributed to making it hard to get a hydrodissection. But fortunately, with careful polishing, I'm able to clean the capsular bag. As I'm polishing, I'm watching the capsulorhexis edge and the area subincisionally, which I wasn't sure if there was a radial run out, but it looks like there isn't. Again, I'm always making sure that I maintain the anterior chamber before I come out of the eye with the probes. Here, I focus past her capsule just a little bit, and you can see a thin membranous tissue with blood vessels in it. This is her retina floating around where it shouldn't be. This is a view I'm not used to. This is her total retinal detachment. I'm definitely not used to seeing this like my retina colleagues do. It's really interesting to see. Back to the cataract surgery. Despite no vision potential, I do decide to place a lens implant. Of course, a basic lens implant, just to give the eye a more anatomically normal configuration. An eye's natural lens separates the anterior and posterior segment of the eye from one another. After lens implantation, I consider placing a CTR, but I knew it wouldn't make a clinical difference for her. And I noticed that the lens stayed very well centered the whole time, even after viscoelastic removal. And given her overall eye health, I decided it wasn't needed. I really wish this patient had vision potential. I'm looking forward to what the retina specialist will say. Here's the patient a few days after surgery. She is thrilled with her outcome and the way her eye looks. Thank you so much for your attention. I appreciate you watching. I'll catch you on the next one. Peace.